to Doctors Rahil Briggs and Diane Bloomfield. They're going to transition from one to the other. So Dr. Rahil Briggs will speak first, and then Diane Bloomfield will speak. Good? Okay. Dr. Briggs is Associate Professor of Clinical Pediatrics at Albert Einstein College of Medicine, Director of Healthy Steps at Montefiore, and Director of Pediatric Behavioral Health Services. She has concentrated on the integration of mental health specialists within primary care pediatrics with a focus on prevention, early childhood mental health and development, and parent-child relationships, and was named Director of the Pediatric Behavioral Health Services at Montefiore in 2013 to spearhead the formation of one of the most comprehensive integrative pediatric behavioral health systems in the nation, which provides services to over 90,000 children and their families in Bronx, New York. She is currently working on a book about integrated early childhood mental health and primary care to be published by Springer in 2016. And Dr. Diane Bloomfield is Medical Director of Family Care Center Pediatric Practices at the Children's Hospital at Montefiore and Assistant Professor of Pediatrics at the Albert Einstein College of Medicine. I take up a lot of time with all the accolades and credentials that speakers have. She has pursued her interests in children's mental health through collaborations with the American Academy of Pediatrics, the Academic Pediatric Association, and the New York State Child and Adolescent Psychopharmacology for Primary Care program. So welcome.
Thank you so much, Denny. Good afternoon, everybody. Welcome. I'm a child psychologist by training, so by definition, I'm a little bit a part of the problem of the way that mental health services have been offered in our country, and I think that's why a lot of us are here today. I started my career in a regular mental health practice in the Bronx in New York, and I was focused specifically on early childhood. But two problems emerged very quickly. Number one, families didn't want to come to a mental health clinic with their young child. If you have a young child, ask yourself if you want to go to a mental health clinic and say, my young child has a significant problem. And number two, when they did come, they often came, in my professional opinion, too late. Things had been going on for years. And when I would ask them, did you tell anybody about this before you came here because he just got kicked out of the 3rd preschool in 3 months and you lost your job as a result? And almost without fail, they'd say, I told the pediatrician. And that was a real shift for me. What was I doing in this mental health practice that nobody wanted to come to? And why didn't I go sit with my pediatric colleagues in the pediatrician's office where families seem to go? I would almost, Dr. Hopkins and Dr. Perrins have talked about how pediatric practice is non-stigmatized. I'd almost go one better than that, and I'd say it's positively stigmatized. And we don't really have a lot of other systems in this country where people are seen as good parents if you go. And everybody goes. So what was I doing in that mental health clinic that nobody wanted to come to? That was 11 years ago, and I'm happy to tell you that now we have a fully integrated behavioral health care system in the Bronx in New York. If you haven't been to the Bronx, come visit us. There are 62 counties in New York State, and usually we rank around 62nd in terms of health outcomes. We have the poorest urban congressional district in the country in the South Bronx. 75% of our children have Medicaid. And so we're dealing with significant risk factors. But I tell you that not to get you depressed midway through your afternoon, but to tell you that if we can do it in the Bronx, we can do it anywhere. So with that, I'll walk you through a little bit of our background that helps guide us, some quick results, and then share the podium with my colleague, Dr. Bloomfield, to really give you the perspective from the pediatrician's perspective about what this feels like to practice in a system like this. The American Academy of Pediatrics, of course, put out a wonderful policy statement talking about early childhood adversity, toxic stress, and the role of pediatrician. Toxic stress is defined as stress that's chronic and unrelenting and this is really key, not moderated by a primary caregiver. So that brings in that parenting piece and the ability of a parent to protect a child from stress. Most pediatricians I know, not the ones in this room, but the other ones, read this policy statement and said, great, I'd love to, tell me how. I don't really even know where to begin on addressing this. Because so much of it is a multi-generational approach, that when we identify children at risk for exposure to toxic stress, it means working with their parents. And that, for some folks, is a real system shift. From the Center on the Developing Child at Harvard University, there are some fabulous policy statements and the like, and research papers on this, really again making the point that pediatric well-being, children's well-being, is predicated on the well-being and health of that child's parents, right? That this is a multi-generational problem we have, and it does me no good to treat a preschool with a mental health or a behavioral health problem and not involve the family. I really might as well just go home, right? I'm just going to send that kid back into the family where we know that a lot of that risk emerged from. So our challenge in primary care and what drives us every day, truthfully, is the idea, is there an opportunity to identify children at risk of developing mental health problems? I'm not worried about how to identify children with mental health problems in primary care. I'm a child psychologist, that's what we do, right? We screen you, we assess you, we can identify. I'm not worried, that's not interesting to me. We're not waiting for children to become obese. We're not waiting for children to have diabetes. We're trying to think about prevention. And why aren't we thinking about prevention with mental health? So how do I identify children at risk of developing mental health problems within the primary care setting? And if we can do that, how early could we do it? 5? 4? Prenatally? That's a hint. And what tools would we use to do that? One really important point I want to make, you're going to hear today about a lot of different screening tools and a lot of different programs. The science is robust. It exists. We don't want to get bogged down with which screening tool or which program. We need to talk about the right setting and payment for these services. But the screening tool that we have started to use is ACEs. The Adverse Childhood Experiences study was done in the mid-90s by the CDC and Kaiser, where they looked at what had happened to you in your first 18 years of life, adverse childhood experiences like neglect, abuse, a parent with a mental illness, a parent who was incarcerated. And then because they were Kaiser and they had all the health records on these folks, and these folks were older adults by this point, they just looked at the correlation between what happened to you in the first 18 years of your life and how healthy or unhealthy you were now that you were 50 or 60 years old. The correlations are shocking. So that if you had 4 or 5 adverse childhood experiences, you might be 4,000 times more likely to have attempted suicide because of something that happened 30 or 40 years prior in that early childhood period. And why is that link so important? Because there's something about brain development in early childhood that is just foundational. It's much like the foundation of a house. If you build it well in those first years, that house can withstand some storms later on. And if that child's brain is built well through parents who have the ability to provide a nurturing environment with limited exposure to toxic stress, that child's brain is a strong foundation to move forward. And if you don't get it right in those early years, it's not to say that you never get it right again. It's just going to be a lot harder, cost a lot more money, and take a lot more time, right? What we're interested in, though, is not just these ACEs that tend to lead to social, emotional, and cognitive impairment, adoption of health risk behaviors, disease, disability, social problems, and even early death. So that people with an ACE score of 6 or more, on average, died 20 years earlier than their peers. And this work has been replicated prospectively in other countries. We want to get underneath these adverse childhood experiences. Again, I don't want to wait for the kid to be depressed, and I don't want to wait for the kid to have an adverse childhood experience. I want to figure out how to prevent these from ever happening. This is just some data to really show you on mental health what happens if you've got 0, 1, 2, 3, or 4 or more adverse childhood experiences, and the prevalence then of mood, anxiety, substance abuse, and impulse control disorders. So our Healthy Steps program, Healthy Steps is another program that is specifically designed to be integrated into primary care pediatrics. We started in 2005 as a pilot program and then got officially sort of anointed to move forward as a Healthy Steps program in 2006. We started co-locating people in primary care, and now we're integrated, and that's an important distinction. Co-located meant that people, which was me at the time, I worked for Einstein, which was our medical school, and I went and sat in the practice at Montefiore 4 afternoons a week, but then I went back to Einstein and wrote in the chart and did things. Integrated means everybody works for the same system, we share the same medical record, additional ways to destigmatize mental health problems. We share the same medical record, and we're working together along with the pediatricians. And we're doing universal screening at every single well child visit, assessment and treatment, referral when needed for a higher standard of care, of not just the infants and toddlers, but their caregivers. So maternal depression screening within primary care pediatrics, and maternal depression treatment within primary care pediatrics, if we can figure out how to get these things paid for. We're screening with the adverse childhood experiences, or ACEs, asking the parents about what happened in their own childhood, because we think that can tell us which children are at risk for exposure to toxic stress prenatally, right? Why wait? The Ages and Stages Questionnaire is the most widely used social-emotional screening tool, and that's our outcome of interest. Social-emotional development is another way to think of pre-mental health, right? We have pre-diabetes, and we focus on that. Social-emotional development is the pre-mental health. It's mental health that doesn't reach a diagnostic criteria, but it's the kid's ability to manage his or her emotions, get along with others, and learn. If we're just thinking about learning but not worried about the kid managing their emotions, they're not going to be learning very much, and we're wasting a lot of our time. The PHQ-9, of course, for maternal depression, and lots of provider education that my colleague Dr. Bloomfield will talk about. I want to quickly share with you our evaluation results, and I want to give you the lay of the land first. We have 2 primary care practices that are matched to each other. They both have general pediatrics residents and general pediatrics attendings. We put Healthy Steps into one and didn't put it into the other. We offered it to all first-time mothers in the practice and their partners, and we enrolled families either during the prenatal period or before the child was 2 months old, because I wanted to talk about prevention, right? If you got Healthy Steps, that meant that a Healthy Steps specialist co-managed your well child care. If any of you have young children right now, you know that you're at the pediatrician pretty often, even if your child is healthy. You're there 13 times in the first 3 years, just because that's what you're supposed to do, according to the American Academy of Pediatrics, right? And so we just co-manage those same visits. It's not a different visit, it's not somewhere else, it's not something else, it doesn't take any more time for the family, it's where they already are, and we're focused on development, behavior, the parent-child relationship, and parent mental health. And if you didn't get Healthy Steps, of course, you just got care as usual. Our question was a maternal experience of abuse or neglect in her own childhood going to be related to poor mental health outcomes for her child? And could we test that by looking at the social-emotional development, remembering that that's really the precursor of mental health? And if we thought that was probably true, then could Healthy Steps make a difference? If we put Healthy Steps in the middle there, could we moderate that relationship, right? This is a quasi-experimental longitudinal follow-up. And again, we enrolled families prenatally until age 2, and we looked at these outcome measures at age 3 on the child. Prenatally until 2 months, excuse me, and then looked at the outcome measures at 36 months for the child, right? And so here are your results, and I'll sort of walk you through this slide. This dark blue bar and the light blue bar are the control group families, and the red and pink are the ones who got Healthy Steps. This is your ASQSE mean score. This is a screening tool that's scored, and if you get a high score on this, it's bad. The cutoff is 59. You see this big black bar. Anything above 59, the child is thought to have at-risk social-emotional development. Again, think of that as your precursor to potential mental health concerns, right? And so what we're showing you here is that in this blue bar are children born to mothers with experiences of abuse or neglect in their own childhood who did not get Healthy Steps. And at age 3, those children had very significantly elevated social-emotional risk scores. Their counterparts over here in the red are children born to mothers with abuse and neglect in their childhood who got Healthy Steps. And as you can see, their risk score is way below that cutoff. Also important are these light bars, though. Because as Denny said, I have 90,000 kids in our system every year. And if we're going to really get to a sustainable, integrated pediatric behavioral health system in this country, we have to think in a population health way. What these light bars tell me is there's no real difference. It didn't really seem to matter very much for the children born to parents without ACEs, right? Great news. That means that we didn't have to give them healthy steps. We don't have to talk about giving everybody in the country an expensive home visiting program. Some people need that expensive home visiting program and most people don't. And even in the Bronx, where risk runs really deep, a lot of our kids didn't seem to need this Healthy Steps intervention, right? So it's a really important way to try to think of who needs what and making sure that the right people get what they need. So now, as I mentioned, we've got about 90,000 pediatric patients. We have 300,000 overall, and our integrated behavioral health system covers adults and children. So all of our 300,000 patients walk into any one of our 21 sites across the Bronx and receive a behavioral health screening as part of their visit. That's just how we do business. We don't pick you out because you look different, smell different, sound different. That's just how we do business. We believe that health and mental health are intertwined. There is no health without mental health, and there sure is no child mental health without parent mental health. To cover 90,000 pediatric patients in 20 sites, we have 21 overall, but one doesn't see kids, don't worry about them. It only takes me 21.8 full-time equivalency providers. And I really want to hit that home. I don't have a cost slide in here, but our costs are about $450 per family per year for the Intensive Healthy Steps Service Program, and $50 per family per year for short-term problem-based consultation in the primary care setting based on an issue that comes up. I want to now briefly describe our overall plan and our overall model, but really bring in my colleague Dr. Bloomfield, who's going to talk specifically from the perspective of a pediatrician in this system. You don't have to say this, but some of our pediatricians say, I'm never practicing again without this. But also about our school age and adolescent work, because that's really a critical piece of it, and I don't want to leave them off of the hook. But essentially our model now is Healthy Steps for Birth to 5, Innovative Child and Adolescent Programming, and then the Collaborative Care Initiative for Adults. Dr. Bloomfield?
Thank you, Rahil. I'm speaking to you as a pediatrician. I've been practicing in the Bronx for 25 years. I love it there, and I practiced there before and after we had this integrated model. And as Rahil said, I never want to go back. The reason is because as a pediatrician and a mom, I always ask, am I providing the kind of care that I want my daughter to receive? And I was really frustrated before I had an integrated program, because I had become adept at interviewing patients and trying to find out what was going on with them, and I had a really big box of tissues on my desk because it usually led to a lot of tears when people were finally able to reveal what was going on in their homes. But then I didn't have a plan for what to do next for these families, and that's where this integrated model has helped me tremendously. The ability to screen across the lifespan of a family using a validated tool, it's been a vast improvement to the quality of care that I now deliver to my families. The screens have given me a window into the way the child is functioning, the way the family is functioning, and they've been particularly effective for my school-age and adolescent population. I think of them sometimes as the silent sufferers, right? They don't really tell you what's going on. They're going to school every day, and then something bad blows up, and by then the parent feels terrible. I told one of my cohorts today that many of my teenagers feel it's fine to tell me a lie, but they can't seem to lie to that paper. And so when they complete that screen, I really am able to have a much deeper conversation and prevent some of the terrible things we all hope to avoid in our own teenagers' lives. The integrated model has also provided educational opportunities for myself and my colleagues. The COR, that's collaborative office rounds. What that means is that we meet as a group with the psychiatrist and the psychologist every other week. We present cases, they teach us how to engage patients, they teach us about mental health, how to manage, how to assess, how to help these families who are now dealing with these difficult things in their lives. All of the children we see will benefit from this training, not just the children who have a poor outcome on one of the screens. Oops. Now, no, Dr. Dwyer is here, and he knows as well as I that 20% of children in the U.S. have a diagnosable mental health condition. And we know this prevalence rate increases in the population I serve, which is the lowest socioeconomic group. Yet despite the AAP's strong recommendation for us to do the screening practices, in national surveys, only 16% of these children with positive screens will receive a behavioral health referral. Why does this occur? Well, as a pediatrician, I can tell you it's probably due to a couple of things. One of them is the lack of available mental health resources, and then there's the additional problem that many of the referrals I would make to outside mental health providers felt like I was sending it out into a black box or the ozone. I would send a referral, I didn't know if the parent went, I didn't know what the provider thought, I didn't know how I could work with the family to meet our shared goals of success for this child, so I often wasn't surprised when they didn't want to go or they wouldn't keep going. Well, in a 6-month study period for our patients enrolled in the integrated program, 26% of all children, so that's not just the children who screen positive, that means 1 in a little bit more than 5, 1 in 4 of the kids in my waiting room were referred to our program here. And I think that's a wonderful advantage to have. One of the reasons I think that this integrated program has been so successful and influences the increased referral rate and the high rates of treatment is the warm handoff. I mean, it's very difficult to accept the idea of a mental health condition in a loved one, especially if the loved one is your child. And so the stigma associated with these diagnoses, plus the parents feeling that it's something they've done wrong, can inhibit them actually coming in for treatment. That's why the warm handoff is so great, because the psychologist works in my area, right? So they meet the family while the family is there already, seeing me. The trust that they have in me, I can transfer over to someone that I trust, that I know is going to give me feedback, that we're going to work as a team together. And you can see on the slide that in our program, 23% of our patients received a warm handoff. And while over half of our referred patients attended at least one session of therapy, this percentage increased to 63% when we had the warm handoff as part of the interaction. This is especially impressive to me as I work in a community in the Bronx where mental health is highly stigmatized. And it's been documented that often my patients are the least likely to seek mental health services. So I am very thankful that I work in an institution that has decided to support such a wonderful integrated health program.
Thank you, Dr. Bloomfield. I really appreciate that perspective. And I think I just want to close by saying this is feasible. You can do this. If you can do it in the Bronx, you can do it anywhere. If you can do it in a population of people who are predisposed to say no mental health services for me, thank you, then you can do it anywhere. Warm handoffs seem to really matter because we are borrowing from the trust given to the pediatrician. As a mental health professional, I'm borrowing from the trust given to Dr. Bloomfield, and that's really critical, and that's a lot of why it's helping. Our conclusions, finally, is that Healthy Steps does seem to function as a moderator between adverse childhood experiences in parents and social-emotional development in children. It's feasible and it's efficacious to integrate pediatric behavioral health into primary care pediatrics and family medicine settings. We have all sorts of different kind of settings, FQHCs, non-FQHCs, pediatricians, it doesn't matter. It works everywhere, we have it everywhere. We need payment reform yesterday. If we do our job right in Healthy Steps, these children will never have a diagnosis. And nobody's paying for that. Although I'm glad to see they're paying in Washington for 3 sessions. But that has to go much bigger than that. And we have to think about mental health in the same way that we think about other healthcare problems, where we work in prevention and we use what we know about prevention science, and we pay for preventive services delivered within this positively stigmatized setting where people really want to go. I agree with Dr. Perrin that we need to train behavioral health providers, but I got that. We're good on that. That's not where we need this sort of congressional influence. We can do that within our own guilds and within our own training sectors. Where we really need the attention is on payment reform to guarantee that these programs don't remain in silos and don't remain in grant-funded locations only, and really spread. This is where children want to receive mental health services. This is where parents want to receive mental health services. And if we can figure out the payment piece, I think we can really move the needle on this. So thank you very much.